Ready.
Good afternoon. I'm Dr. Hal Danzer, co-founders of Southern California Reproductive Center. Today our topic is egg freezing right for you? And we'll talk about age and success rates and then kind of what to expect in terms of the process. And I presume most of you who are here with us today are uh, women that are looking to preserve their fertility for the future, and we'll have a chance for some questions and answers at the end.
Great. Hi, I'm Dr. Diana Chavkin with SCRC. Excited to be here with you today and speak with you about egg freezing. It's one of my most favorite topics. I think of it almost as kind of preventative medicine, which I think is the best kind. And so happy to go through the process with you and have you think about whether this might be right for you.
So a lot of the beginning of the journey of selecting the doctor and the facility of those things are, important for any kind of medical procedure. As I mentioned, I'm kind of the co-founder of SCRC. We've been here for 25 years and have had one of the largest embryology laboratories and practices in Southern California. I think we've always been very intent on keeping our eye on the horizon for the latest developments. Um, we're very lucky in that we have a large laboratory with a good number of embryologists and physicians here to be able to offer the very best and latest technology for egg cryopreservation. Um, Everyone always asks, how did you get involved in fertility work? Well, my grandmother was a midwife in rural Montana in the early 1900s, where there were no doctors, and women obviously took care of other women in terms of obstetrical needs. Obviously, there wasn't much in the way of fertility enhancement back then, but everybody got pregnant when they were late teens, early 20s. So there was a lot of infertility issues, and there was a lot of delaying of childbearing. So a different world. We've come a long way. And again, as you'll see as we go through, the technology that now comes to play to allow women to freeze their eggs or freeze sperm or embryos for future fertility is very, very good.
I'm Dr. Diana Chavkin, as I mentioned. So I've been with SCRC since May, and it's been such an incredible place to practice. Prior to that, I'd been practicing in Los Angeles for about 10 years, and prior to that, I practiced for a number of years in New York City. So happy to be here at SCRC. The fact that this clinic is owned and run by physicians is so incredibly important to me. It makes it very clear here that medicine and patients are first above all else. And so it's just really been a pleasure to work here and take care of patients. The lab is absolutely phenomenal, and at the core, our success rates are very clearly dependent on our lab. And our lab here is one of the longest running labs in Los Angeles. So just so proud to be part of the long history here and the amazing success rates, and to be in such great company of the physicians who are so incredibly well experienced. And we really do work as a team here. So it really is nice to be part of this team. So
So,
sorry,
do you want
go
to
ahead.
continue? Go
Yeah,
ahead.
you can go.
So more than 25 years of experience. So a lot has happened in medicine in the past 25 years, and certainly in reproductive endocrinology. Pregnancy rates with IVF when we started were in the 15, 20, 25% range, and today we're 70, 75% pregnancy rates with in vitro fertilization. We didn't know how to freeze eggs at that time. It was a technology that evolved to what they call a quick freeze now, where they put eggs in a salt solution to draw out the water and then freeze it within an hour or so after it's retrieved. Um, so we have again, a state-of-the-art embryology lab. We have surgery center here as necessary. And we're at 4 locations to provide less drive time for our patients. So what goes into a embryology laboratory? And we have about 8 to 10 embryologists now. Again, we run 7 days a week. And that allows us to, as you see, double witnessing, which is really important. When you're embryologist, on the morning of egg retrieval, the eggs are taken by one embryologist. That embryologist follows through and does the freezing, and there's no switch over. Again, anytime you switch over, there's a chance for errors. So double witnessing, you have a second embryologist that kind of looks over the shoulder and verifies that all the names and birth dates are right. Very important. And again, this flash freezing is the newest technology in the past probably 10 years now. We also, with IVF, you do genetic testing of embryos. So women that freeze their eggs, when they're ready to get pregnant in 2 years or 10 years, can thaw the eggs, make embryos, and genetically test the embryos. Genetically balanced embryos, when you transfer a single embryo, their pregnancy rates are close to um, 75% today. One of the other things we have in our laboratory is embryoscope, which is kind of time-lapse imaging photography. So you can see how an embryo divides from day to day. Embryos that divide symmetrically, 2, 4, 8 cells, do a little better than ones that got 1 to 3 or 2 to 5. So again, it's a technology that allows us to pick out the very best embryos for the first transfer. So today we're talking about age factor, and age is really everything in terms of one's fertility. Uh, how to optimize your cycle, how to get your body ready to do an egg-free cycle, success rates and kind of what to expect, what's all involved, how much time it takes, um, a little bit about meeting our team. So next slide. So here we are. What is fertility preservation? And again, it's a process of helping individuals protect and save their ability to have their biologically owned children in the future. So that involves freezing eggs. We freeze sperm for some men. The age factor for men is not huge, but we have some men that are wanting to freeze their sperm under age 40 or 45. We know that younger sperm do better than older sperm in terms of pregnancy rates. So who are the best candidates? Anyone looking to control the future? Not that any of us can totally control our future, but to give us a better option. Um, Obviously, individuals that have genetic conditions may look to freeze eggs and for testing later on. Patients are undergoing chemotherapy. We see many patients that have breast cancer or other cancers that are going to start chemo, which diminishes the egg reserve. If you could freeze the egg beforehand, then luckily the uterus preserves its implantation ability a lot better than the ovary. And individuals waiting for the right time to start their family. And, obviously when you're in your 20s or early 30s, it's hard to know when it's going to be the right time for your family. But freezing the eggs then sort of gives the opportunity, takes that weight off your shoulder about being able to have your own family easily in the future. So these are just graphs that tell you about age. And, I think everybody's aware of the fact that one's fertility changes with age. And, age 35, 36 seem to be the kind of break point for many women, not for all. There are some women that have lower egg reserves, in their late 20s or early 30s. But these are just kind of averages. But it really speaks to the point that the genetics of the egg is really what is important in terms of its potential in the future. We talk about chromosomes, those where all your genetic pieces are lined up. Chromosomes don't separate cleanly as you get into the late 30s and early 40s. And that is the age effect. It's this kind of sticky chromosome effect. And right now, we do not have the technology to change that or reverse it. So we're really left with getting the eggs earlier on to save, and they're good for 10 years plus, and it does not change the genetics of those eggs. So an egg at 32 is just as good as what it is when the woman is 42. Next slide. And this is just illustrates what the ovary looks like on the left. You see all those little circles. Those are microscopic eggs that have cells around them, and how they're all clustered together at birth. And at birth, there's what, 1 million cells. And by the time puberty, you're down to maybe 50,000. We don't know why the ovary loses all those eggs so early in life. But there's a lot of research going on at the present time to try to determine why that happens and perhaps reverse that or modify it to some degree so that there isn't this loss of eggs so early in life. And then unfortunately, you look on the far right, and here's a woman that was 50 years old, and there's maybe 1 or 2 eggs. And again, women struggle in their late 40s to get pregnant because even with fewer eggs, the genetic quality of the egg is compromised also. Next slide. So again, patient evaluation, when you come in and take a medical history about, and the examination really has to do with ultrasound, which looks at the uterus for polyps or fibroids, the structure of the uterus. We've seen 2 patients recently had essentially a double uterus. Again, that's rare, but again, an ultrasound that lets you know that structurally, anatomically, the uterus is fine. And then the other thing we look at is the ovaries, what they call the basal follicle count. How many follicles do you have in a given cycle that can be brought to maturity for retrieval and freezing? We also look at certain hormone levels in AMH. So next slide. So on the left, you see this AMH, anti-Müllerian hormone. It's a tough word to remember, but each egg in the ovary is surrounded by clusters of cell that make AMH. And we like AMHs to be 1 or 2.5. So it really is a blood test that tells you about a woman's given reserve. It also tells us if your AMH is a little bit low, use a higher stimulation dosage when you do the process. And then on the right, there's a ultrasound, and you see the ovary, which is just about the size of your thumb. But you see all those dark circles, those are follicles. And in each follicle is a microscopic egg, but it's immature. But to retrieve an egg and to fertilize it or freeze it, you have to have maturity. And that takes about 10 or 12 days. That's when a woman usually ovulates. And but we'll go into that a little bit later. So the AMH blood test and the ultrasound are the 2 tests that really tell us about one's reserve. And these are tests that can be done by your gynecologist. I think there's many GYNs that, ask women in their late 20s and early 30s to start to monitor their AMH and their follicle count. Next slide. So what's kind of we talk about a holistic approach, and I think that has come certainly into focus for women doing IVF and egg freeze. Both the processes create a certain amount of stress for everyone, hormonal changes, emotional investment in the process, and how do you get yourself ready for that? And we talk about good nutrition and exercise, and those are 2 things that have been shown in multiple studies. For almost any sort of medical procedure, the body responds better with good nutrition and exercise. And we'll go into that a little bit later. Acupuncture, certainly is stimulation of the nervous system. It may reduce stress. It may help to harmonize the body. And those are all good things to do prior to egg freeze. Next slide. Before we get to that, there's a lot of women that are on weight loss programs. Um, but certainly we know that the body may respond better when your BMI is less than 30. And I think that's something that we always talk to our patients about before they begin to embark on the journey of egg freeze is how do you get your body in the very best place, nutrition-wise, exercise-wise, and weight-wise. So nutrition, and certainly there's the Mediterranean diet that's been shown to be beneficial to reduce heart disease and a variety of other common disorders, folic acid, B12, and the omega-3s. And I think almost everybody's aware of the fact, the benefit of these in your general daily diet. Next slide. And supplements, everybody asks about supplements. And again, folate, vitamin B12. We always check for thyroid, which is a hormone, but we look at vitamin D, which is another element that we always test for, again, to improve one's general health and so on. CoQ10 is a supplement that's been used for years, and a number of studies seem to indicate that it may be helpful for some in increasing a higher fertilization rate and possible higher quality embryos. It's sometimes used with men to help improve sperm count and quality. And then we talked about vitamin D. We always check at vitamin D levels. Many of us run low, and supplement of vitamin D certainly can have some beneficial effects in terms of one's reproductive capacity. Next slide. So acupuncture, I mean, numerous studies looking at what acupuncture actually does. It stimulates the nervous system, may increase blood flow to the reproductive organs, which may help to balance hormones, may relieve stress. I think I've had acupuncture several times for different things, and I think it does allow the body to harmonize so that you can have a better result medically from any condition. Next slide. So again, things to avoid. There's a lot of toxins, a lot of controversy today about what are dyes and how that affect your general health. Smoking and alcohol obviously have been very clearly identified as lowering one's fertility. Tobacco is a kind of a vasoconstrictor and diminishes blood flow. Alcohol, 1 or 2 drinks a week is probably fine. But many women preparing for IVF or egg freeze, try to eliminate the alcohol in your life. Eat well and exercise. Cannabis, is there's a lot of kind of conflicting studies. I think there are studies that suggest that it's probably not the best in the world in terms of preparing for IVF or freezing eggs. We generally like to try to eliminate all chemicals. A lot of people are on psychotropic agents, and they seem to be pretty safe, and you don't have to go off and upset one's mood balance. So, and then tobacco, obviously, everyone should not smoke. That's not good for you. So I'm going to hand it over to Dr. Chavkin, and we'll have questions later on.
Great. Thank you for that, Dr. Danzer. Good. So now we're going to start talking about kind of some of the logistics and the nitty-gritty details of kind of what an egg retrieval will look like. It's so interesting. A lot of times during the consultation, I kind of give an overview, sort of the reasons for doing this and kind of the pros and the cons and all of the many things we talk about. And I have to say that the number one question when the whole conversation is over is, well, how does this look like logistically? What is the timeline? How long is this going to take? And of course, it's an understandable concern because people want to know, how is this going to affect the rest of their lives? We know women are busy, people have careers, they have family and things going on. So it's very, very understandable. So that's kind of what we're going to go over today. So initially we'll do a baseline ultrasound. And so usually we'll have a woman be instructed to reach out with the beginning of her period. Sometime in the first few days of her menstrual cycle, we'll have her come in and do a baseline ultrasound. So the baseline ultrasound gives us a lot of information. So of course, we'll take a look at her uterus, kind of see if there's anything potentially concerning. But the main thing that we're really focused on when we're thinking about egg freezing is the ovaries and the follicle count and the egg supply. That gives us an idea of a woman's ovarian reserve, gives us some sense of what we might be able to expect when we do the egg retrieval in terms of an idea of how many eggs we might be able to retrieve. It also really helps us give us an understanding of what starting dose of medication to use. So we can use a varied levels of medication to help to stimulate the eggs, and getting an initial baseline ultrasound gives us some clue as to kind of where to start. Now, as the process goes along and a woman starts taking the medication, we will tweak that dose and alter the dose based on how she responds, but the initial dose is often based on her initial follicle count because that's reflective of the ovarian reserve. So that again, that's the baseline ultrasound. And then sometimes we'll use birth control pills leading up to the stimulation. Sometimes we won't. But regardless, we'll do another ultrasound if a woman does go on birth control pills, again, just to confirm that she doesn't have any cysts, and also to get an estrogen level to confirm that there isn't high estrogen levels. So once we see that everything is suppressed, we'll then have her take hormones in the form of an injection. Now, these hormones are gonadotropins, things like FSH and LH. Now, these are the very same hormones that a woman's brain naturally will produce to stimulate the eggs in her ovaries. But in a natural cycle, much lower levels of FSH and LH are produced because in a natural cycle, one egg gets recruited and one egg becomes dominant and ovulates. In the egg freezing process, we want to salvage and recruit all of the follicles, all of the eggs that were sitting, or as many as we can, that were sitting in a woman's ovaries that would have otherwise really died that month, right? So the only eggs that we can get to grow and develop are the eggs that are sitting there waiting to get recruited at the beginning of the ovulatory of the menstrual cycle. In the normal menstrual cycle, one egg gets recruited and released during ovulation. All the other eggs that month die off. What we do in this egg freezing process is because we're having a woman take much higher levels of these gonadotropins, it allows us to rescue and salvage these eggs that would have otherwise died. So that's kind of the idea here. And so the way that it works is she'll take subcutaneous thin small needles injections. So not like when you get a vaccine and it goes in the muscle and it's painful for a day or two, not that kind of injection. These are subcutaneous thin small needles, very, very thin needles meant to be self-administered, go under the skin. And we coach our patients and we tell our patients how to take the medications so that they're very well aware and very comfortable doing it. The woman will take the injections for a period of around 10 to 12 days. And during that time period, we'll have her come in for blood work and ultrasound for what we call monitoring visits. So usually these are very quick visits. People can come very early in the morning before work if they want, or in the middle of the morning if they want to go to work and then come back, go in and out. It's usually very quick 10-minute visits where they get a blood draw and then an ultrasound, usually with our sonographer, sometimes with the physician, where we will look at the development of the eggs. And we'll basically, we're measuring the follicles. So the follicles are the pockets of fluid that are in the ovary that house each egg. And that's what grows, and that's what we can see on ultrasound. The egg is of course microscopic, so we can't see the egg, but we assume that there's an egg in each follicle. And that's what we're measuring and growing to make sure that the eggs in the follicles are becoming mature and responding to the medication. So when a woman comes in for these monitoring visits and we get the blood work and ultrasound, we get the results each time that she comes in. And usually we have a woman come in maybe 3 to 4 times during that 10 to 12 day period. She's not coming in every day. This is not meant to disrupt her life in any way. So we get that information when she comes in for the monitoring visits. As I said, we tweak the dose of the medication. We might increase it, we might decrease it, we might keep it the same. And then based on that, we determine when we want her to come back. Usually it's every few days. And then we get her to the point of the egg retrieval procedure. So once we see that there's a good number of mature follicles, and we assume that an egg is mature when it's housed in a follicle that measures around 20 millimeters in size or so, 18 to 20 millimeters. And so that tells us that there's likely a mature egg. And so when we see enough of those mature follicles and we see a hormone level, an estrogen level that is also consistent with a nice response, we'll say, okay, she's ready for her retrieval. And so how do we get that process completed is we'll have her take a final injection, a trigger shot, which induces the initiation of meiosis. So it kind of initiates the maturity of the egg. And then 36 hours later, we'll then have her come in for the egg retrieval procedure. So let's say on a Monday, she comes in and we say, oh, it looks like there's a nice number of mature eggs. We'll have her take her trigger shot Monday night. And then 36 hours later, on a Wednesday morning, we'll have her come in for her egg retrieval procedure. And so this kind of lays it out for you: baseline ultrasound, plus or minus birth control pills, ovarian stimulation for about 10 to 12 days, monitoring visits during that time period, trigger shot once we see mature eggs, and then the egg retrieval is performed. And that, I think, goes over the timeline. Next slide, please. So for the egg retrieval procedure, during this procedure, we'll have the woman completely asleep. She won't feel anything, completely under anesthesia. The physician will then place an ultrasound probe in the vagina attached to a needle. The needle is very thin and it pierces the vaginal wall. And this picture makes it look like the ovary is kind of far from the vaginal wall, but in fact,
Seemed like there was a freeze on her. Oh, now it's back again. So I think Dr. Chavkin is just looking at the bottom image there where you can see the little needle going at about the 11 o'clock position in each follicle. And it literally takes, 15, maybe 20 minutes to retrieve eggs if you have a lot. And again, it's under very light propofol anesthesia. You wake up in 5 minutes afterwards and you're out the door in an hour. Most people take Tylenol. I think we still lost Dr. Chavkin, but so he was storing frozen eggs. They are stored here on the premises. They're in liquid nitrogen. Um, Even if the power goes out, the tanks are good for days. Um, so if they have an earthquake and it takes a while to get to a few days to get the tanks out, well, then they are safe. Um, there's electronic monitoring all of the time. I don't know if we're going to get her back or not. So how do you freeze an egg? And they talk about survival rate is 87%. Uh, Here's a picture of an egg. It's microscopic, and it's essentially jelly. And to freeze an egg, you have to put it in a salt solution to withdraw the 70%, which is water, and the egg then kind of shrinks down, and immediately is put in liquid nitrogen. And thaw rates today are 70–80%. It's very good technology. And fertilization rates 70–80%. So that's probably the most important thing. She's back now.
hi, sorry about that. I don't know what happened. It just sort of just
I
stopped
did the
working
other
as I
I
was
did the
speaking.
other slide.
Thank you for taking over. Sorry about that. Good. So, right. So I think you'd kind of gone over that first part there about cryopreservation outcomes. So yeah, just really incredible progress over the past few years, and that we can really offer this as standard of care for women who are interested in increasing their chance of having a child in the future. The fact that we could freeze eggs and then use them, 10, 15 years later and take these eggs, thaw them, fertilize them with such good success rates to create embryos and healthy, beautiful babies. It's really an incredible thing. So, yeah, approximately 6,000 babies are born from the egg freezing process. No, we know from many, many studies there is no increased risk in maternal fetal complication. No increased risk of congenital anomalies when compared to the naturally conceived population, which is really amazing, and no increased risk of aneuploidy or malformation in egg freezing populations compared to the rest. So really incredible. Next slide. Okay, so recovery time, most patients can return to their daily routines the day after treatment. Now, it really depends on what a woman's specific occupation is. So I think most people kind of, for whatever, even many, many jobs are really, a lot of it is computer work and behind a desk. And so that's absolutely fine to go back to by the next day. I mean, really, this process shouldn't take a toll on a person's life or interfere with a person's life very much at all. I mean, really, while a woman is taking injections, she's going to work, she's going about her life. As I said, we really try to make things easy where people can come in super early if they wanted to for their blood work, ultrasound, go to work. They should not really need time off from work in any way. And people will have dinner with their friends, right? It's kind of, just really life is normal. The really only day that people are out of commission is the day of the egg retrieval. And mostly that's because of the anesthesia. By the next day, anesthesia is completely out of their system and they're really good to go back to work. Shouldn't really be too much pain or discomfort afterwards. Now, for women who are, police officers or EMT workers, postal workers where they're lifting heavy things. I mean, for those women, I generally say take off a few days up from work, but for most people, most occupations, they're good to go back the next day. And of course, recovery process is different for every patient. People may experience bloating, a mild discomfort, but that's normal. Now, I will say that is really for the most part. Now, we always counsel patients that there's always theoretically a risk of things like hyperstimulation syndrome or infection, bleeding, injury to the bowels or bladders, right? Those things are actually extremely, extremely rare. But if they do happen, of course, a woman would have to take off a little bit longer from work, and those things really are limited and they do resolve. So some frequently asked questions. When should I consider fertility preservation? I mean, it's interesting. I feel like the cutoff or the age at which people are really coming in for egg freezing and fertility preservation is actually younger and younger, which is actually great. I think that, any woman, I think a woman who's maybe in her late 20s, early 30s, definitely by mid 30s, who's potentially interested in having a child in the future and is not ready at the moment, should absolutely consider freezing eggs or freezing embryos if she has a partner that she definitely wants to have children with. But if she doesn't have that partner, freezing eggs is really a smart thing to do because it potentially really opens a door that we know will close eventually. And as Dr. Danzer mentioned earlier, we don't really know when that door is closing or closed for any given woman. So the sooner a woman can be proactive and freeze some eggs for her future self, it really will provide her with a much higher increased chance of having a child in the future. Can you do multiple cycles of egg freezing? Absolutely. And many women do choose to do that. So, in general, well, I'll tell you, a lot of women come to see me for initial consultations and they're, often say, how many eggs should I freeze? How many cycles should I do? And, of course, we want to take into account a given woman's age, her AMH, her ovarian reserve, how many children she wants to have, when she thinks she might want to have children, right? So we have to think about all of that. But in general, I say, listen, there's no need to put pressure on yourself. All you can do is one cycle at a time anyhow, right? And in any given cycle, we will try to get as many eggs as we can, while of course keeping you safe and healthy. We'll get as many eggs as we can. And then after that cycle, we can talk about well, how many eggs did we get? Based on your age and the number of eggs that we got in that cycle, we can give you some estimation of how many children or what your percent of having one child or two children with that number of eggs. And then based on that information, you can decide if you want to do another egg freezing cycle after that. And I would say most people who decide to do a second or a third egg freezing cycle really do them pretty, quickly one after the other just to kind of get it out of the way. And it's an absolutely fine thing to do. How long can egg, sperm, embryos stay frozen? I mean, as far as we know, there really is no expiration date. I mean, we've had embryos that have been frozen and eggs been frozen for many, many years, like 10 years or more. So it really should not be a concern. Of course, as people age, I mean, people develop health issues as they age. Dr. Danzer spoke with you before that, it really is the age of the egg and the uterus does not age to the degree that the egg does. And that's why fertility preservation in the form of egg freezing, embryo freezing, sperm freezing is such a great thing to do. It is, though, important to think about that as people age, there are other health implications and things that to consider. So although we can keep these things frozen, we just have to think about the age of the person that is going to be conceiving with them at that specific age. So when do I find out how many eggs will be frozen? So we will always try to give an idea of kind of what to expect as we're going along. So when we get the AMH level, we get the follicle count, we get an idea of ovarian reserve. You should never really be in the dark in terms of, what your expected ovarian reserve and what your outcome might be. When we do the final trigger shot, we'll be able to see the follicle. So we'll be able to give you some idea of how many mature eggs with round we think we might get. And of course, there's variability, right? It's never an exact guaranteed number. And then we will let you know the day of the egg retrieval how many eggs we got. And then the day after, we'll know how many mature eggs are frozen. And so you should get that update. And what age do you recommend other fertility treatments instead of egg freezing? I mean, it really, I don't know that it's necessarily based on an age. I think it depends on kind of where a woman is in her life in terms of, whether she has a partner, whether she's interested in using donor sperm, whether she's interested in carrying herself or a surrogate. So it's definitely a little bit more of a complex conversation, but definitely worth thinking about. So promotions, we have a winter freeze special, 25% off an egg freeze cycle. Please look into that. This is a very special promotion that we're currently offering. We have an upcoming donor and surrogacy information night. I know this is not necessarily tied to what we're talking about exactly at this moment, but it really is such a great thing. I love it when we have these in-person events. So please join us, or if you know of anybody who might be interested, please pass this along. It's a very nice, unique opportunity. So yes, SCRC, this is our fertility physician team. So Dr. Mark Suri, Dr. Hal Danzer, Dr. Carolyn Alexander, Dr. Susan Maxwell, and myself. Dr. Susan Maxwell sees patients in Santa Barbara and Ventura. Dr. Suri and myself, we see patients in Beverly Hills and Pasadena, and Dr. Danzer and Dr. Alexander see patients in Beverly Hills. So we cover a wide geographical area, and we hope to meet you. So you can ask us your questions, and we are here to help.
Yeah, one of the questions everybody asks is just what's the usual? Well, our goal is to get 15 or 20 eggs on a stimulation. And for women under 35, that usually gives you probably 85% chance of at least one live birth. When you get to be 37, 38, 15 to 20 eggs, you're down to maybe 65% chance of a live birth. So again, age has a lot to do with it. Now it's different. There are some women at 32 are going to get 10 eggs, and there's some women at 42 are going to get 15 eggs. So that's the important thing about having coming in for evaluation or having your gynecologist do the AMH or the basal follicle count. Where are you in this spectrum? Because, again, our goal would be 15 to 20 eggs in a given IVF cycle. So they have what's your eggs and your age, then you could put it into a probability calculator. It really gives you a pretty good idea how many live births would result from that first cycle.
Yeah, and you make a good point, right? It depends on when they get referred and how old they are, because if they come, and they're maybe a bit older, their ovarian reserve is somewhat lower, they might need a few cycles to get to that 15 egg number, which is okay, right? That still potentially can give them that 15, 20 eggs, but it might take them more than one cycle to get there.
Yeah, but most are going to be able, women in their early 30s are going to be able to get 15 to 20 eggs most of the time. So,
Yeah, absolutely. Great. Well, thank you all for joining us today. And feel free to reach out. We're here to answer your questions. Thank you.